Welcome, everyone. Thank you all so much for being here for the webinar today. It is my pleasure to welcome you to this webinar following the recent launch of an important new research report, The State of Multicultural Mental Health in Australia. I'm Carolyn Nikolowski, the CEO of Mental Health Australia. If you're not familiar with our work, Mental Health Australia is the national independent peak body for the mental health sector. We represent around 160 member organisations, including service providers, professional associations, organisations representing people with lived experience and their family carers and kin, researchers, and state and territory peak bodies. The Embrace Multicultural Mental Health Project is an important part of Mental Health Australia's work, really contributing towards creating a mental health and suicide prevention service system that better meets the needs of people from multicultural backgrounds. Embrace is delivered by Mental Health Australia in partnership with the Federation of Ethnic Communities Councils of Australia, FECA, and the National Ethnic Disability Alliance, NEDA. We're absolutely delighted to be here today following the recent launch of this critical new research report, which has been delivered through Embrace with the research undertaken by Western Sydney University. We're really excited to hear from a number of people today on the importance of this research and its key findings and recommendations. Thank you so much, everyone, for taking the time to join us. To begin this webinar, I acknowledge the traditional owners and custodians of the lands on which we are meeting today. I'm joining you from the unceded lands of the Bunurong people of the Kulin Nation. I pay my respect to elders past and present, and I acknowledge and pay my respects to Aboriginal and Torres Strait Islander peoples joining us today. I also recognise the unique and critical contributions of people with lived experience of mental health challenges and suicidality, and those who love and care for them in championing mental health reform. We celebrate people of all backgrounds, genders, sexualities, cultures, bodies, and abilities. Just a few quick housekeeping notes before we get into the webinar today. This webinar is being recorded and it will be made available via the Embrace website and YouTube channel in the coming weeks. The closed caption feature is available via Zoom today to support accessibility. To turn captions on or off, click the CC closed caption button in your Zoom toolbar. If you're having any issues with the webinar today, please make sure your Zoom platform is up to date, and we recommend restarting Zoom if need be. And if any of the conversations or presentations today cause distress for you, please draw on your support networks, and the Mental Health Australia team will also pop the details of a couple of services in the chat. I will now hand over to Michelle Possingham, the Director of Programs and Sector Development at Mental Health Australia, who will provide a background to this research report and the aims of today's webinar. Thanks, Michelle.
Thanks so much, Carolyn, and thank you so much everyone for being here today. We all know that Australia's rich diversity is one of our greatest strengths. However, despite evidence of the unique mental health challenges faced by multicultural communities, research in this area remains really limited. That meant it was particularly important when in May 2023, the Commonwealth Government announced funding for Embrace to deliver the State of Multicultural Mental Health in Australia research report that we've come together to discuss today. It's been quite a journey, and I think you'll agree it's an important one. The report we're presenting today aligns with government priorities to improve mental health access and equity for multicultural communities, and is grounded in many years of work to better understand and respond to the unique mental health challenges faced by multicultural people and communities in Australia. The report represents the first major research report of its kind in over 10 years, updating and building on the 2013 report, Mental Health Research and Evaluation in Multicultural Australia, Developing a Culture of Inclusion, which was led by Associate Professor Harry Minus. This important new research provides a contemporary snapshot of multicultural mental health in Australia, bringing together data and evidence and community and lived experience perspectives to inform more effective policy and service responses. This report and Mental Health Australia recognises the need for a mental health system that responds meaningfully to our diversity, one that can genuinely meet the unique needs of multicultural communities. Thank you all for joining our webinar today as we explore this new research, its key findings, and talk about its recommendations. It's with great pleasure that I hand back to Carolyn, who will introduce the first of our speakers joining us today. Thank you.
Thanks so much, Michelle. It is now my pleasure to introduce Zinab Al-Halali. Zinab is a member of the Embrace Lived Experience group, and she'll be sharing her insights on the importance of this research. Thanks, Zinab.
Thank you, Carolyn. Firstly, I'd like to acknowledge the traditional custodians of the land on which we meet today and pay my respects to elders past and present. It's a privilege to be here as a member of the Embrace Multicultural Mental Health Lived Experience group and to share some reflections on multicultural mental health and the State of Multicultural Mental Health in Australia report. Mental health does not exist in a vacuum. For many people from multicultural communities, conversations around mental health are often shaped by stigma, shame, trauma, discrimination, and even displacement. And seeking support is often not always straightforward. This report gives us some insight and combines some national data, research, and importantly, the voices and experiences from communities themselves. One of the key findings was that people from culturally and linguistically diverse backgrounds often delay seeking help. This isn't because people don't care about their mental health, but rather reflects the barriers that exist and the reality of our systems have not always been designed with multicultural communities in mind. This report often also highlights what works. It tells us that culturally safe and strength-based approaches matter, that services work better when they are co-designed by the communities it's supposed to serve, and that lived experience should be valued and embedded in leadership and decision-making. One of the strongest messages from the report is that multicultural mental health isn't just the responsibility of multicultural organisations, it's everyone's responsibility, from mental health services to government to community organisations, clinicians, researchers, and communities. As a member of the Embrace Lived Experience group, we know that lived experience is an expertise and that the experiences of migrants, refugees, carers, families, and individuals who have navigated these systems provide important and valuable insights that data alone cannot capture. Our stories remind us that people are often more than statistics. When communities are engaged, when people with lived experience are genuinely included, and when services are culturally responsive, we can create mental health services that are equitable, inclusive, and reflective of modern Australia. Ultimately, multicultural mental health is about ensuring that no one feels that they have to leave behind their language, culture, identity, faith, experiences in order to receive the support that they need. But it's also about recognizing that every person deserves care that is effective, culturally safe, and compassionate. I hope that today's discussion continues to help move us from awareness to action and to finally long-lasting change. Thank you.
Thank you so much, Zinab, for sharing those insights and reflections. It really reinforces the importance of this work. So we now have the opportunity to hear directly from Associate Professor Shamaran Slua-Ewan from the Western Sydney University, who led the national consortium of researchers who contributed to this report. So Shamaran, over to you. Thank you.
Thank you. Thank you so much, everyone. And thank you so much for those wonderful words, Zainab. You really kind of set a lovely platform to begin the conversation. Okay. Let me just start by quickly, just basically, one of my plans are for today is to take you through an overview of the report by taking you through how the research was structured. I'll then spend some time talking a little bit about the key insights, and then we'll conclude by discussing the recommendations. But before I begin, I'd also like to take a moment to make three important acknowledgements. Firstly, I very much want to acknowledge the traditional owners on the land in which we are gathered today, appreciating that we're all meeting online and from far and wide in Australia. And I'd like to also pass my respects and wishes and pay my respects to elders past and present. Second, I'd like to acknowledge all of those with lived and living experience of mental health challenges, and in particular those who participated in this research. Your voices were very much at the heart of this work. And thirdly, I'd like to talk a little just to acknowledge the lasting effects of migration and potentially trauma and the effect it has, recognizing that today's global landscape continues to shape the well-being of many Australians and the sense of safety that individual families and communities across Australia are feeling at the moment. For those of you who haven't had an opportunity to have a look at the report, this is an image of the report, the cover of the report, and here is the reference. It's available online and it's available through various websites, including Mental Health Australia and the University of Western Sydney's website as well. So this slide gives you a sense of the expertise or the breadth of expertise behind this report. Our research team brought together experts and academics from across many specialties, including mental health, migration, public health, biostatistics, and social policy. The diversity of this expertise was really important because multicultural mental health sits at an intersection of so many fields, and that no one discipline could potentially do it justice. The report is designed to speak to a wide range of people, from clinicians, policymakers, people working in mental health services, those who work in settlement and refugee support, disability support, and so on. So whether your background is in direct service delivery, systems design or management, support, advocacy, there is something here that is relevant to everyone's work. And as I won't be able to cover everything today, I really encourage you to take the time to read the report and to focus on sections that are most relevant to you. So let me just begin by just setting the scene or the broader context at the time this report was being researched. Australia's population diversity is growing rapidly. This is a national strength, but with this rapidly changing demographic and social policy landscape, it is also presenting a challenge for multicultural mental health policy and practice. We also know that there are health inequities that persist and can arise from things like language barriers, cultural mismatch, the lack of visibility in data sets, which all mean that mainstream services may not always be aligned to specific community needs. Research also has demonstrated that there are distinct mental health challenges within certain CALD communities, and that these can be linked to pre-migration trauma or ongoing stresses such as racism, family separation, socioeconomic pressures, and so on. We also know that mental health help seeking can sometimes be problematic in different community groups. So the research was designed to answer two core questions. The first one being, what do we currently know about the state of multicultural mental health in Australia? And the second one being, what are the current and emerging good practices for supporting mental health of multicultural communities? And to answer these questions, we undertook three distinctly different but interconnected studies. So the first one was looking at a secondary analysis of the 2020 to 2022 National Study of Mental Health and Wellbeing. And this was done so that we could understand the patterns of prevalence and service utilisation for common mental disorders. The second one was a rapid literature review of Australian studies between 2012 to 2025, looking at community-based mental health interventions for CALD populations in order that we could identify what were good practices, what were barriers, and what were enablers. And the final study was a series of national consultations with multicultural community members, service providers, and sector professionals in order that we could build consensus on what were the most effective strategies to support multicultural mental health. On this slide, I just want to kind of orientate you to the research framework that we utilized in trying to understand and draw our conclusions. As I said, our goal was to develop a multi-layered, evidence-informed picture of multicultural mental health. And to do this, we used the 6 pillars model of scientific knowledge as our framework. So recalling what I just said were the 3 studies, each one of these was tapping into different pillars of this model. So the national data set gave us observational evidence at a population scale, so real world patterns of what were mental health conditions and how services were used. The literature review was giving us evidence around what were being tested in Australia in terms of mental health interventions in a community setting. And the stakeholder consultations brought together expert knowledge, lived experience, cultural knowledge, the kind of information that comes from on the ground understanding to tell us what was really happening in terms of what helps people engage with services, what gets in the way, and where consensus lies in terms of the strategies that generally work for communities. So altogether, these 3 studies were allowing us to draw upon these 6 pillars and to build a much more complete and nuanced understanding that any one particular study could ever offer. So turning to the first study, this was the secondary analysis of the national study of mental health and well-being. So in terms of prevalence rates, what we found was that the 12-month prevalence rates of anxiety and affective disorders was lower overall amongst overseas-born individuals compared to those born in Australia. However, when we looked more closely, a different picture emerged, so that the recent arrivals, those that arrived between 2012 to 2022, were reporting higher rates of these disorders within the overseas-born group. So this suggests to us there are important nuances that cannot be kind of picked up if we're just doing a very broad aggregate. Secondly, in terms of service use, we found very clear differences in how people were using services or reporting how that services were being used. The Australian-born individuals with 12-month anxiety disorders, for example, were more likely to have received 20 or more consultations in the last 12 months compared to the overseas-born. However, when we looked at how long it took for people to get into treatment, we also found that there was some evidence to suggest treatment delays, so that the overseas-born people were more likely to report treatment delays for over 10 years, which suggests that there are these nuances around service use and accessing care. However, what is important to highlight here is that there are limitations within this data set. So firstly, the number of people with low English proficiency is quite limited. And this really reduces our understanding to be able to kind of deep dive and understand the patterns and experiences of these particular community groups, which past research has suggested that they are particularly vulnerable groups. And secondly, because of issues around needing to adhere to privacy, we needed to create broad aggregates. And so we really couldn't really drill down deeply into particular cold groups or linguistic groups. However, overall, these findings suggested to us that while overall prevalence rates appear to be lower in those born overseas, there were patterns of vulnerability within that group, and that service access was nuanced and does require further research. Moving on to study 2. So this was a rapid review of community-based mental health interventions. And we did this so that we could synthesize the contemporary evidence on what approaches seem to be effectively supporting cold communities. We focused on Australian-based studies, both peer-reviewed and grey literature, published between the period of 2012 to 2025. In total, we found 41 records, and most appeared after 2018, suggesting that this is a growing but relatively young evidence base. The studies covered a range of cold populations, and they were defined in various ways, from country of birth, language spoken, ethnicity. And most of the interventions were occurring at that kind of early intervention space, so mental health promotion or prevention or early intervention. There were studies, however, that integrated treatment approaches such as cognitive behavioral therapy, mindfulness, trauma-focused approaches, or support groups for people with severe mental illness. And a consistent feature across most of the studies was there was an attempt to tailor linguistically, culturally, and contextually, the context of the needs of the communities. So what did the evidence tell us? Well, it points to the value of care that needs to be culturally safe, integrated, and strengths-based approach. Most crucially, it needs to be co-designed with community. This is the approach that makes a real difference to service engagement and mental health outcomes of these population groups. The evidence also suggests that mental health literacy and anti-stigma work really matters, not just with communities, but also service providers. Because when both sides are better equipped, they are more likely to recognize when they need help, more likely to seek help, and more likely to find services more inclusive when they when they seek that help. We also looked at the rapid review to identify what was coming up in terms of barriers and enablers to access and engagement. So starting with barriers, the review highlighted there were several factors that were making it hard for POLD communities to access or to stay engaged in mental health services. So mental illness stigma, which discourages help seeking, language and communication challenges, and a range of cultural and social factors that were shaping how mental health is understood and therefore how services are approached. Also, there was evidence of broader systemic and structural issues, which create additional obstacles at that service and system level. With respects to enablers, the literature was pointing to a number of factors. This included culturally adapted interventions, which use flexible and inclusive methods to meet people where they need to be. And the very strong theme that came across was workforce and how services were delivered, as well as community partnership and co-design. Integrated models of support and trauma-informed strength-based care was also noted. So the key message here from the literature was that access and engagement doesn't just depend on individual factors. It also depends very much on how services are designed, where they're located, who delivers them, and how they're communicated. Which now brings me to study 3, which was our national stakeholder consultation. Now, this slide gives us a snapshot of the scope of these consultations. We engaged in a series of meetings across 12 locations in Australia, face-to-face, with multicultural community members, service providers, and professionals across health and community sectors. And we were trying to develop as strong a geographic and cultural representation as possible. Sites included regional locations such as Kalgoorlie in WA through to Shepparton in Victoria, and also places like Fairfield in New South Wales, which for most of you will know has been an area that has been resettling large numbers of humanitarian entrants for a number of years. As I said, this broad spread was deliberate. We wanted to hear from communities beyond major cities, and we wanted to capture as diverse a range of experiences across different settlement contexts, different service locations, and so on. The participant data on this slide, I think, really speaks for itself, and I'm actually very genuinely proud of what we were able to achieve. We had a total of 95 participants, representing a balance of stakeholder perspectives, including, most importantly, lived experience as both mental health clients and carers. Participants came from 38 different countries and spoke 43 different languages, so quite a diversity. So from the stakeholder consultations, we were able to identify 22 principles and 7 enablers for good multicultural mental health care, and that they were then ranked in order of importance by the participants themselves. A few themes came through very strongly and consistently. Firstly, that care needs to be culturally safe, it needs to be trauma-informed, it needs to come from a strengths-based approach. This is not a nice to have, it's a foundation. Trust, empathy, and equity were values that need to underpin practice. And without trust in particular, people simply won't engage. A diverse and well-supported bilingual bicultural workforce was identified as essential, and participants were very clear that services needed to be designed for the communities alongside them, so with the communities rather than just done from the outside. Recognizing lived experience and contextual realities, so migration history, settlement experiences, was also very much strongly emphasized. And finally, there was a very consistent agreement and strong agreement that anything to be sustainable and to deliver equitable outcomes required a whole of systems approach and not just isolated programs. So coming back to that first question, which is what do we know, what's currently known about the state of multicultural mental health in Australia? So one thing is very clear, we are an increasingly diverse population, which is shaped by different migration pathways. And this brings both strengths, but it also brings important challenges for mental health policy and service delivery. It means we need approaches that understand intersectionality, they understand the local context and evolve with the community's need. In terms of the national data, the 2020-2022 National Study of Mental Health and Wellbeing, it gave us a good starting point, but it is limited. And I said, as I said, it was related to the fact that there are lower levels of limited representation of people with low English proficiency, and also that we couldn't really drill down deep into particular COLD subgroups. However, even with those constraints, our analysis demonstrated to us that people from overseas-born backgrounds, while having lower rates of anxiety and affective disorders overall, still had different particular nuances to these prevalence rates, so that those who had arrived most recently had higher rates. We also saw clearer service use differences. Australian-born individuals were more likely to have experienced 20 or more consultations in the last 12 months, and that overseas-born individuals were more likely to report experiencing treatment delays for over 10 years. Finally, in terms of our rapid review, it was coming through quite clearly that culturally safe, strength-based, co-designed models of care can make a difference, and that mental health literacy and anti-stigma work are critical levers that make that difference. The literature was also very clear on access and engagement. So what are barriers and what are enablers? In terms of barriers, things like language, communication difficulties, limited interpreter and multilingual resources, cultural insensitivity, practical issues, and ongoing stigma. But our knowledge of enablers is growing, and the stakeholder consultations really added new insights to that picture. So both across the literature and the consultations, there was strong agreement that genuine partnership with COLD communities is at the heart of good practice. Cultural or community organisations, leaders, informal care networks, and families are often the first point of support, and they carry a significant load. So supporting these networks with psychoeducation and practical help is essential. Good practice means designing services with communities and not just for them. Co-design and co-production needs to be backed by proper resourcing to ensure that the programs feel relevant and trusted. Embedding mental health support within familiar community spaces makes access much more easier, and acknowledging the intersectionality helps services generally meet people where they're at. The literature review also highlighted promising models of care, those that are focused on trauma-informed programs, those that are culturally safe, those that have a person and family centered point of view, and that integrate mental, physical, social, and spiritual needs. But to deliver this well, the whole workforce matters, and the importance of expanding and retaining a strong bilingual, bicultural workforce is crucial. Alongside building cultural responsiveness across mainstream services, primary care, settlement services, disability sectors, to name a few. And finally, improving practice requires better data, not only in national data sets, but in collecting timely and meaningful client and carer data, which is essential in shaping service design and driving continuous quality improvement. So this brings us to the recommendations. And in our report, we grouped our recommendations into 6 areas of strategic focus. So let's take recommendation 1, and that is to fund culturally and linguistically tailored interventions to meet multicultural mental health needs using a systems approach. In practical terms, this means interventions that are designed to make sense within communities, reflecting their values, their language preferences, their spiritual frameworks, and their lived realities. It includes community awareness campaigns in multiple formats and languages in order to improve mental health literacy and reduce stigma. It means creating welcoming service environments so that CALD community members and clients feel safe and that they are then supported with trauma-informed, culturally grounded care. It means delivering care and services in clients' preferred language, using bilingual, bicultural staff or professional interpreters, matched for gender or other relevant factors where possible, and addressing directly issues around confidentiality. And it means in having person and family-centered care that accounts for intersectionality, generational differences, and socioeconomic factors. So in short, recommendation 1 is all about making care fit for purpose. Recommendation 2 is about access and equity. Governments must provide adequate and sustained funding so that services and NGOs can remove barriers and deliver equitable care for CALD communities. It speaks directly to what literature and stakeholders were telling us, that barriers are persistent and structural. Language, cost, transport, restrictive criteria, inflexible models, limited geographical or regional availability, complex referral pathways, and a low awareness of where to go for help. It calls for mental health information in multiple languages and formats, audio, video, infographics, to name a few, that are then distributed in channels that communities actually use. It emphasizes flexible delivery, outreach clinics, telehealth, and other models that can reduce place-based disadvantage. It highlights the need for clear and accessible pathways into services. So things like soft entry points, simplified referral pathways, and navigation support. It addresses affordability and eligibility criteria that currently exclude some groups, and it places responsibility on primary health networks to embed cultural safety into how they commission services, how they address, in order to address gaps and regional disadvantage. In short, recommendation 2 tells us that equity requires a genuine rethink of how we design, fund, and communicate services. Recommendation 3 focuses on community partnerships. The mental health sector must build stronger connections with community members that are from CALD communities, including those with lived experience, their families, their carers, and the community more broadly, so that they can actively shape the services they're meant to support. I should say. The sector should be partnering with community organisations to design, deliver, and evaluate programs using culturally tailored co-design approaches. It means empowering communities, working with cultural leaders to identify and support community champions for mental health, and creating pathways for community members to become advocates within the system. It means promoting cultural identity, especially for young people, that fosters pride and, most importantly, belonging, because we know that these are protective factors that matter for mental health outcomes. It calls for governance structures to include meaningful CALD representation, with accountability built into referral pathways, performance measures, and quality standards. So in summary, this recommendation recognises that trust is built when communities see themselves in the system, not only as recipients, but as co-designers, leaders, and decision makers. Recommendation 4 is moving CALD leadership to the policy level. It calls on governments to ensure that CALD community voice and leadership in multicultural mental health policy development, implementation, and evaluation is there. This is grounded in human rights and legal frameworks. Recommendation 4 is emphasising the sustained and dedicated funding, including remunerating people with lived experience for their contributions, because community-led work requires resourcing and not just goodwill. Stakeholder consultations consistently raise the point that multicultural communities are often subsumed under broad categories such as diverse populations, which can make their specific needs invisible. The absence of a dedicated national multicultural mental health policy was also a gap that was identified. The recommendation here also calls for funding to build capacity amongst COLD community organisations and to provide grants to support community-led mental health interventions and initiatives. Recommendation 5 is about workforce, and it was by far one of the strongly supported areas in our stakeholder consultations. This recommendation calls for investment in bilingual, bicultural mental health professionals, workers, interpreters, clinicians, peer support workers, and so on. It means creating real career pathways, leadership roles, recruitment and retention incentives, and education to employment pathways. It specifically proposes that scholarships to support bilingual and bicultural students into mental health qualifications such as psychology, social work, and counselling are needed. It also calls on expanding the availability of interpreters with mental health training, particularly for newly arrived communities and emerging languages. Critically, this recommendation makes it clear that cultural competence is not just the responsibility of bilingual and bicultural staff. It requires cultural and trauma-informed training for all senior personnel, managers and providers, including people from GPs through to first responders. Cross-sector capacity building is also important, ensuring that health, settlement, disability, NDIS workers, to name a few, are equipped to be able to support people from diverse cultural backgrounds is called upon. And it highlights the need for practical tools, multilingual information, service directories, and mental health advice. So in short, recommendation 5 is about building a workforce that can actually deliver culturally safe care at scale, both now and into the future, with the training, supports, and real career structures that are needed to make that happen. Moving on to the last recommendation, which is 6. Now, this is very much around knowledge and data foundations that are needed to underpin sustained improvement. It calls on the Australian government to adequately fund research and national agencies such as the Australian Bureau of Statistics or the Australian Institute of Health and Welfare to support and build scientific knowledge around multicultural mental health and address outstanding data gaps. It calls on targeted research to inform service and policy development. So things like needs assessments, evaluations, and intervention studies. But importantly, using culturally safe approaches that build in co-design. It calls on targeted oversampling of selected COLD communities and national studies, particularly, for example, the National Study of Mental Health and Wellbeing, in order so that we can generate more meaningful, granular insights into small but vulnerable groups while maintaining statistical reliability and maintaining privacy requirements. It highlights the need for stronger data literacy and infrastructure across the sector so that client, carer, and community feedback can actually continuously inform quality improvement. So in short, you cannot fix what you cannot see. So better data is not just a technical exercise, it is a justice issue. So to conclude, Australia's growing diversity is generally one of our greatest strengths. And what this research has shown us is that there are real opportunities to build upon that and to strengthen our mental health systems so that it generally serves all Australians, regardless of where they were born, where they currently reside, what languages they speak, or what pathways brought them to Australia. The 6 recommendations in this report are really meant to help guide the next phase of work, and I hope that I've provided a window into where and what is needed next. And as I said at the start of this presentation, this report is meant to speak to a wide range of people, hopefully a wide range of people that have joined us today. And I really encourage you to take the time to have a read and to think about what you're able to take forward in your own context. And if you'd like to know more or to continue the conversation, my colleague Elsa Bolano here, his email is listed here. Please reach out, and thank you so much for listening again.
Thank you so much, Shamaran, for that really wonderful presentation and for sharing the detail into the approach to the research, along with the key findings and recommendations. I think it's really impressive to see such a comprehensive approach to the research to give us this up-to-date snapshot of the state of multicultural mental health in Australia and having really clear and well-considered recommendations to guide our collective approach to improving multicultural mental health going forward. So thank you so much. I would also like to thank all of our speakers today and everyone who has participated both in this research project and the webinar. It is our hope that the findings and recommendations from this research report can really support policymakers, service providers, and the broader mental health sector in planning, commissioning, and delivering more inclusive and effective mental health supports for multicultural communities in Australia. I think the research really makes clear that there is a lot of work to be done. But importantly, it also provides us with clear examples of what's needed and what works. And it's really clear that culturally responsive and strength-based and co-designed models consistently show higher acceptability and stronger engagement and better outcomes for people from multicultural communities. It's also really clear that improving mental health literacy and stigma can also play a key role in helping people to get access to support earlier. So, as we move to wrap up this session, I would like to recognise and thank in particular people with lived experience of mental health challenges and their family, carers, and kin, along with those people from multicultural backgrounds who informed the research and the webinar today. It is so important that the work we're doing reflects what is meaningful to the community and reflects the expertise and experience that is available. And thank you in particular to Zinab for sharing her insights with us today. We encourage you to really engage deeply with this research and its findings and explore what the implications mean for you and for your work and for your role. This is something that we will certainly be doing here with our partners through the Embrace project and at Mental Health Australia more broadly. I would also like to take this opportunity to thank the Minister for Health, the Honourable Mark Butler, and our colleagues at the Department of Health, Disability and Ageing for making the investment into this really important area of research and for working alongside us as we conducted the research. And of course, thank you so much to the consortium of researchers led by the University of Western Sydney, along with colleagues at the University of Melbourne, UNSW, and the University of Canberra. And particular thanks again to Associate Professor Shamran Slower-Ewan for leading this work. And so I know we are wrapping up a little earlier than we were anticipating today, but I hope you enjoy getting a little bit of time back in your diaries. As we close the webinar, there will be a short participant survey that pops up, and there was a link in the chat. So we would really value and appreciate your feedback and insights to inform our continued work. So thank you again so much for your time today. I hope you enjoyed the webinar and hearing these really important insights, and have a wonderful rest of your day. Thank you all.